much. Thank you for kind words. Respected dignitaries on the dais. I am presenting our work which we did last year on effect of DIMS lenses on children who are not responding to low concentration atropine. These are my financial disclosures. Now, first of all, what are the key factors as to why exactly myopia progresses in a school-going child? There are two major bulk. One is the near work and second is because of the altered dopamine release. Near work causes peripheral hyperopic defocus. We had a paper on that. So the available literature on control of myopic progression says that, with optical, you have these, some of these options that you have. And with chemical, you have low concentration atropine in variable dose forms, mainly in 0.01% and 0.05%. Who is a non-responder to atropine? Any child, if the refraction continues to progress, despite good compliance of more than -0.5 diopter per year, and an increase in the axial length of 0.2 millimeters is myopic progression, or it is a non-responder. The non-responders to 0.01% atropine ranges from 20 to 50% in various studies. The non-responders may be completely not responding even after putting atropine drops, or may have slowed down the progression, but yet they are continuing beyond 0.5 diopter. Now with this background, we decided to study the effect of MyoSmart or DIMS lenses as an addition with low concentration atropine eye drops on myopic progression in children who are not responding to low concentration atropine eye drops. We had around 10 children who were non-responders. They were enrolled in the study, who were already on atropine and were asked to continue atropine. This was a non-randomized single-arm interventional study with the glass power was increasing more than 0.5 diopter per year. The primary endpoint was progression at the end of 1 year. Now at the end of 1 year, these were our observations. The upper one shows glass progression and the lower one shows axial length progression. Now out of the 10 children, 2 children still progressed beyond 0.57 diopters. And if we take those into consideration, the mean progression would be 10 children. The reason these 2 children have been separated from the other 8 children is to know that there were the DIMS glasses were good enough only for 80% of children, and 2 children yet progressed. But if we will take all the 10 children, then we will see that the mean progression was 0.39. So that will have a masking effect, and we won't be able to know that it doesn't work in all the patients. So low concentration atropine drops are known to reduce the myopic progression. This is very well known. There was a paper in the previous session also. It has been years. Now this is the landmark study from where we all started using atropine by Audrey Chia. This was 1% atropine was used, and there was a follow-up study which was published in 2013. So it has been almost a decade. Now it is very well established that atropine does work. Non-responders to LCA drops are around 20 to 50%. The dose can be increased, or alternatively, we can prescribe peripheral defocus lenses. Now DIMS is a defocus incorporated multiple segments which makes peripheral refraction myopic and slows down the progression of myopia. This is very well documented that peripheral retina is actually responsible for the ocular growth. This was the study done in macaw monkeys way back in 2007, followed up in 2009. There was another study followed up in 2013, and the final study was published by Earl Smith III Jr. in 2016. I don't have all those studies, but this was the follow-up of his thesis. Lam et al. Showed that DIMS versus single vision lenses shows great progress. They showed that myopic progression was halted by DIMS lenses. There was a follow-up study in 2022. They reported a slowing down of axial length. And in their final 6-year study, they compared all the 4 groups, and they did show that DIMS glasses do slow down the myopic progression. The rebound effect is not significant. And selection bias was obviously one of the major limitations. With all these 2 modalities going together, we could not find a single study reporting what happens when you use atropine with DIMS. After we have already presented this last year, we saw one article came up last year. We already got this article published in AIOS that was published in last month of AIOS. So this is already there in publication. So this was one study in 2022 which talked about the possibility of using DIMS and atropine as an adjunct, but they did not publish the results. So we did peripheral refraction in all these patients. The study was unique, as I said, the DIMS was prescribed in conjugation with LCA eye drops. So in conclusion, DIMS lenses do show initial promise in reducing the progression of myopia in children not responding to low concentration atropine when glasses were given in conjunction with atropine eye drops. So thank you so much. Thank you.
What age do you want to start DIMS? And what age do you want to stop DIMS?
No. So this is a very general question. You can start at 5 years of age. So I always talk on myopia and I say that you have to document the progression. The age at which you are comfortable at documenting the progression. If you have an axial progression documented, you can start DIMS. Unfortunately, children less than 4 years won't let you do axial length, and so bulk of the work is between 5 to 15 years of age.
Any upper limit of refractive error?
10 diopters. So DIMS lenses cannot be made beyond 10 diopters, and 4 diopters of astigmatism.